So it seems that none of you have any questions to ask from any of the speakers. So as sir said, maybe you understood everything or understood nothing. So let me just find out what all have you understood. What is heart failure as you understand? Yeah, and anyone from the last table, what is heart failure? Whatever you understand. I won't proceed till I get answers. So it's a very interactive session. The lady with spectacles at the back. So you have to understand, see, every 2-3 years the definition keeps changing. It confuses everyone. The original definition, which is almost 60-70 years ago, was the simplest and holds true. The heart is a pump. It's not able to pump blood out, or it's too stiff to fill in blood and again not able to pump out. So it's a pump, the pump is not working. So whatever blood is there, it's not going forward and it's going backwards. So all the symptoms come from that. It's not going forward, so fatigue, syncope occurs. It fills up backwards, lungs get filled up, shortness of breath, the rest of the body gets filled up, swelling over the feet and ascites. So if you just stick to the original older definition, things become very simple. Why do you need newer definition? Because initially when this definition came in, people understood that all these problems are because of that pump. We started trying to improve the pump. So we gave drugs to improve the pump, we gave drugs to reduce the congestion. So patient improved, went home. But long term, over 5 years, 10 years, the long term outcomes did not improve. Then we understood that even though it's just a pump which is failing, then the body is trying to compensate. The blood pressure is being pushed up, the heart rate is being pushed up, the heart is dilating and trying to contract better. And initially that's also very good, but later on that becomes overcompensation. The heart becomes very fast, the blood pressure tries to go up very much, the heart gets stressed out, then it fails. So compensation becomes overcompensation, and so that is not good. So then we understood that you have to reduce that overcompensation, and then the outcomes started improving. That's why the definitions kept changing, that now it's a syndrome and there are multiple manifestations of syndrome. Then they realized that the pump is like this, it's a contraction. But if it contracts well, it doesn't relax, doesn't open up well. The heart won't fill. So then they realize even though we measure only contraction, we are not measuring the relaxation, the stiffness of the heart. Then you realize that there's something called heart failure preserved ejection fraction, because we were only measuring ejection fraction. So a new entity came up, heart failure preserved ejection fraction. For instance, if you have anemia, hyperthyroid, your contraction will look perfect, but patient will be in heart failure because the heart is moving very fast, the output is not going so well. Patient goes into heart failure. That's why the definitions keep changing. So how do you diagnose heart failure? Keep sitting, huh?
Fluid retention, or with the help of some blood reports, the anti-pro-BNP, BNP, or reduced ejection fraction. With that help, we can diagnose the heart failure.
So
thank you, sir.
First there are. So keyboard चल नहीं रहा शायद. Excuse me. Tech support. Keyboard चल नहीं रहा शायद. एक बार check करो. अब आया. So there are. Just give me full control of the thing. नहीं तो नहीं आ रहा ना. एक बार आके check कर लो. So you have to have some symptoms and signs of heart failure. That means there's shortness of breath. If the patient is symptomatic more on lying down, that is called orthopnea. And if the patient goes to sleep perfectly, gets up at night and is not able to breathe, कुछ नहीं हो रहा ना. आप इधर. So you have the symptoms what look like heart failure. Signs, there are capitations, patient is swollen. So that is the signs, and then you have to confirm it. So symptoms and signs. Symptoms and signs, and then you have to diagnose heart failure by some parameters. Parameters will be an echo and a biomarker. So while none of you really need to do echoes or everything, though I have trained my heart failure nurses to even do echo. They can do echo also. But there is no harm in knowing how to read a report. So when you get a report of echocardiography, what you have to read is, are the valves normal or abnormal? What are the LV dimensions? What is the ejection fraction? Is there anything written about some valve contracting more or less? So learn how to read the reports, because you will understand the kind of patient you are dealing with. Biomarkers, the common one that we use is either BNP or NT-proBNP. Most of us are using more and more NT-proBNP, but either of the two can be used. Just remember grossly, if it's more than 300 or so, patient has some form of heart failure, but it can go up in infections, renal failure, and lung infections also. So it can go up because of non-heart failure causes, but usually we think of it as a marker of heart failure. And if, for instance, the patient's BNP initially is around 2000, with treatment is coming down to 1000, then you know the patient is improving, responding to your therapy. But if it's not coming down, that means congestion is there and patient is not responding to your therapy, and it's a thing to worry about. So you made a diagnosis, then you have to find a cause. So the commonest cause of heart failure in India and the world is ischemic heart disease, coronary disease, so a previous myocardial infarction, or there is some constriction in some of the coronary arteries, which is the commonest cause. There can be various manifestations. So first will be coronary artery disease. Then there will be some form of cardiomyopathy like dilated cardiomyopathy. And finally, rheumatic heart disease. Rheumatic heart disease in India is still prevalent, it's not gone away. So patients coming with various forms of mitral valve disease, aortic valve disease will manifest with heart failure. So if you're at a referral center, you'll get more and more such patients, and if you're in a clinic, you might get less such patients. Then treatable causes. We did a survey in the villages of North India, Haryana, and what we found was, in that place, the commonest cause of heart failure at that point was untreated hypertension. Because patients were having shortness of breath, they were being given bronchodilators, aspirin inhaler was available, so everyone was given aspirin. We checked the blood pressure was very high, not detected, not treated. So look for treatable causes. And see, what happens is, if your doctor is there, his contact time with the patient might be just 5 minutes. You have much more time. You're seeing the patient, listening to the patient, talking to the patient. He'll give you a bunch of so many papers, and you'll find blood pressure was always high. You picked up hypertension, which was missed by the resident, by the doctors, because at that time no one bothered. You're so busy, you didn't even check the blood pressure. This happens, repeatedly happens. So this should be picked up. Then, for instance, your patient is stable for heart failure with past 2 years, 3 years. He comes, he's very short of breath, there's no doctor around, or makes a phone call to a helpline if you have helplines running, and says, I'm feeling short of breath. So what do you have to look for? First thing is the patient taking the medicines as prescribed by the doctor? The commonest cause of worsening is often the patient has stopped his medications. He could not take them because he was on a government prescription finished, he could not get them from the government dispensary, or medicines are too expensive, he's unemployed, he cannot buy all the medicines. We gave him Arni, dapagliflozin, very sick, but the most costliest medicines. Whereas if you knew the patient was not very rich, you could have given very cheap drugs like enalapril, furosemide and metoprolol, and he would have done fairly well without going for such expensive medicines. So medication, is the patient taking medication, is very important. Then the next common cause is infection. Quite often they'll say, हाँ एक हफ्ते से खांसी हो रही है, बुखार हो रहा है, तब से सांस फूल गया. So you can pick up all these things by talking to the patient, listening to the patient. You don't need any investigations. Then the heart rate could be very fast. So if you check the blood pressure, the heart rate will also come with that. You'll find the heart rate is very fast. So tachycardia of some types can cause worsening of heart failure. If you put a pulse oximeter, you'll see the pulse, supposing it's like this, then stops, then like this, It's very irregular. Patient has gone into atrial fibrillation, one of the commonest causes of tachycardia, causing worsening of heart failure. So you have to always understand, diagnose the heart failure, confirm it by echo. But if the patient comes decompensated, look for a treatable cause. Anemia, patient was bleeding from somewhere, has had an injury, there's bleeding, so anemia can cause worsening of heart failure. So you've done everything, you made a diagnosis. Now comes the treatment. We'll start with the acute treatment, as Sir said. So now patient comes to the emergency, one of you is on duty, there is no doctor around. Patient is gasping, respiratory rate is 40 per minute, saturation is down to 85%. What are the first few things you will do? Let's start from this side. So you will give oxygen. Okay, very good. What else will you do? Lasix. So how much? Yeah, so give a reasonable dose of Lasix. Don't give 5 milligram, 10 milligram, 15, 20. Give a good dose. Give 40 mg of Lasix at least. If the patient gives you a OPD card which says he's already on 100 or 200 mg of Lasix, then you can easily give much more. Give 100 mg of Lasix. Because he's already taking 100, then he will not respond to 10, 20, 40 milligram. Give a reasonable dose. So for this, obviously, along by putting oxygen, you have to put in an IV line. Never forget, IV line, a good IV line is necessary. Given an IV line, given oxygen, given Lasix, then NIV support तो देर से आएगा, पहले और कुछ करो. How will the patient lie down? Flat, up, so proper. See, simple things will make the patient much more comfortable. Then if the saturation is not picking up, you put in an NIV mask. How many of you can apply a NIV mask comfortably? 1, 2, only 2 persons. So all of you should know how to put an NIV mask. It's not rocket science, it's a simple thing. You just have to ensure that the mask is airtight. If the patient can't tolerate a mask, just apply the mask gently, don't tighten it. Tell the patient to breathe deeply, make the patient comfortable, because suddenly having a mask on the entire face is claustrophobic to any person. Even we can't tolerate it. Then as the patient is becoming comfortable, tell him that you will gradually tighten the mask. Once the patient is comfortable, trusting you, you can easily tighten the mask. With that, the patient will start feeling better. You don't have to intubate such a patient. So all these things can be done at the nursing level. You do not need a doctor to come and tell you these things. What else can you do? Patient is very restless, very anxious. I'm giving you the clues also. Very restless, very anxious, tachycardia is there. He's not staying still, just moving about, throwing things about. You don't want to restrain patients. That's only for children. Gasp कर रहा है वो, support नहीं मांगेगा. Before that, you can give IV morphine. See, morphine will very low dose. We give only 1 to 3 milligrams only. Morphine will calm down the patient. As the heart rate comes down, the congestion also comes down, because tachycardia goes down. Okay, and it helps in pulmonary decongestion. So these are simple things you will first do to calm the patient.
Morphine is not available nowadays because of government regulation. In that case, what should we do?
बताओ. No, by this time the doctor has come, so the doctor has to tell you give morphine. Fenta दे सकते हो, but that is whatever is available. Okay, so you done the initial therapy, then you can move on to more advanced forms of therapy. By that time, the doctor and you are working together, patient is becoming comfortable. If the patient is not becoming comfortable, is gasping, saturation is going down, from NIV mask, you can end up putting the patient on a ventilator. Because ultimately, you want the patient comfortable, hemodynamics stable. If the blood pressure is not staying up, but blood pressure is around 70, 80. Which inotropes? One by one. Okay, noradrenaline. What else? Dovitamin. Oh, what else? Adrenaline. What else? Name all the inotropes, then I'll discuss which one to use first. Vasopressin, डोबेटामिन तो हो गया, दूसरा डी कौन सा? Dopamine. So see, if the blood pressure is down, you would want to start either noradrenaline or dopamine, whichever is easily available. Start one of these drugs, that because you first have to bring the blood pressure up. And blood pressure you don't want to bring up to 120, 130, just want to be having a blood pressure, reasonable blood pressure of at least 90 systolic. So once noradrenaline is the drug of first choice, dopamine is the second drug, so you can combine both if you're getting desperate. Third drug possibly, dobutamine, the disadvantage, it causes vasodilation, so it can't be the first drug. You give it first, BP will fall further and only help if the LV function is down. So then you can add dobutamine, you're getting desperate, adrenaline, vasopressin, ultimately all 5 drugs. But if you reach 5 inotropes, then you know the patient is in trouble. You have to move beyond that and think of something else, which means you have to give some kind of circulatory support. The simplest thing which your cardiologist will possibly want to do is put an intra-aortic balloon pump, that is one option. Or if you're in a rich hospital, you can think of Impella, but most of us are not working in very rich hospitals with rich patients. So Impella is out. So it amounts to only drugs and going up till IABP only. But in the meantime, you have to also find the cause of acute heart failure. The commonest cause of acute heart failure will be a myocardial infarction. So at that point, the cardiologist has come and you do a ECG. That's the minimum you need. You do a ECG, you find ST segment changes, ST elevation, myocardial infarction, shift the patient to the cath lab, start opening up the artery. And as you're opening up the artery, along with that, if necessary, a IABP should be put and the procedure should be done. So cause has to be treated. After the first 5 minutes of support, you have to start actively looking for a cause. For instance, it's not even a cardiac patient. Patient had a road traffic accident and he had a chest injury. There's a pericardial tamponade. That will not respond to all these measures so easily. You have to treat that. Patient has a knife inside here. So you just pull out the knife and patient will crash. Because there's a tamponade inside or a pneumothorax. So you have to quickly, after the first 5 minutes, start searching for a cause and treating that. So once you've done all that, patient is stable, patient has reached ICU and sir is managing the patient. He doesn't happen to be there at that time. Now patient, when he comes to you, is breathing comfortably, rate of around 25 per minute, blood pressure is down to 90 systolic. Patient is sitting quiet, lying down quietly, saturation is 99%. What will you do? This is a trick question, so think carefully and answer. Anyone? You don't have so much time. You can't spend 2-3 minutes thinking what will you do. You have to respond. If you make a mistake, you get corrected, but you have to respond fast. Anyone? You will do nothing. You have to first see the patient. Just looking at the blood pressure on the screen doesn't mean you start responding by rushing and creating panic and giving inotropes. See the patient. If the patient is lying comfortably, breathing comfortably with a BP of 90, is passing good urine, is talking to you, then just looking at the blood pressure is not something you respond to. But if the patient is going to altered sensorium, he's not passing urine, he's cold, getting confused, then you know that this 90 blood pressure or a lower blood pressure is causing problems. So then you have to use one of those inotropes, see if the patient is dehydrated, give a bit of fluids and manage that balance. So just don't respond to numbers. Just because you're seeing a number of 90, don't respond to it, wait for something to happen. So you stabilize the patient, patient is ready to move out of ICU, shifts to the ward. In the ward, he's now off dobutamine and he's on just injectable Lasix twice a day. What is the next step? Patients come to the ward, eating properly, just about to start walking. You have to mobilize, making walk. What medications do you want to start? See, the reason this is necessary is because the nurses are consistent. If you're posted in a ward or ICU, you're always there. The residents, the fellows, the younger doctors keep changing. They're not always fully trained. They might not know exactly what to do and what not to do. But if you know exactly what to do, you can say very politely, sir, Would you like to reconsider this particular order, or would you like to consider giving this thing also? So that's why nurses have to know at least something about management of heart failure. You don't have to know the intricacies of doses, all the side effects and all the interaction, but at least basic things you have to know. So patient is now in the ward. What do you want to do? You had all the lectures. I'm not asking anything new. The lectures I've already finished. I'm just, before I start my slides, I just want to interact on these issues. So what do you want? See, now is the time to start planning till the point of discharge, what medications you want to do, what general measures you want to take. So what medications do you want to start in this patient? You keep naming whatever you heard since morning, and I will just keep typing them. So this is how I remember it. It's the ABCD of therapy. So you will give beta blockers. You will give ACE inhibitors. Okay, what else? Ramipril is one of the ACE inhibitors. Good. Enalapril is the oldest, but it's the cheapest also. So if the patient can't afford, enalapril, ramipril are good drugs. What else can you do? Any more vasodilators that you know of besides ACE inhibitors? Then you have angiotensin receptor blockers. For instance, losartan is there, candesartan is there, valsartan is there. Not all drugs have been tested or approved for heart failure. So there are some restrictions in terms of which drugs can be used, but the common one would be, and the cheapest one would be losartan, which can be used for heart failure. Then another A, arginine. So Sidmus, Vimeda, it's got multiple names now. There are so many other brand names. The costliest ones are the oldest drugs. So the Sidmus, Vimeda would be the costliest, but there are generic versions also available, which are much, much cheaper. So one of the A's has to be used. That means one of the vasodilators has to be started very low doses, because the sick patient who's just come out of ICU was perhaps even on inotropes. So start on a very low dose. A doctor will start it, but supposing he's a fresh doctor, he'll start on a very high dose. You can caution the doctors that, sir, this patient has just come out of ICU. Do you want to start a lower dose? That's why it's important for you to have some idea of the doses. Beta blockers, you can use any of the 3 approved beta blockers. That means it can be carvedilol or sustained release metoprolol or bisoprolol. Only these 3 are approved. You cannot give propranolol, you cannot give short acting metoprolol, you cannot give IV metoprolol. See, repeatedly I've stabilized patients in our ICU and I write down only one thing: do not give beta blockers without asking me. The resident comes at night duty, the duty shifts, he's not seen the file, he sees heart rate is 130. He tells the nurse, sister, beta blocker do, IV do. Morning when I come, the patient is on a ventilator. Evening I had seen the patient was absolutely stable. So beta blockers have to be given very, very carefully, and it's not in the ICU. Even in the ward, you give beta blockers only when the patient is absolutely stable, is walking around, and the IV diuretics are switched to oral diuretics, because the benefit of beta blockers will come after 1.5 to 2 months. It's not that beta blockers will bring in a benefit within days. ACE inhibitors, ARB, ARNI will bring benefits within days. Beta blocker benefit will come after 1 to 2 months. So there is no hurry to bring in a massive dose of beta blockers so fast. Patients just come out of ICU. Then diuretics. See, these patients will be on furosemide or torsemide, one of the diuretics, but the diuretic which benefits the patient on the long-term therapy is a mineralocorticoid receptor antagonist. So drugs like spironolactone, they are beneficial for the long term. So the patient should be, and usually they are on one of the mineralocorticoid receptor antagonists. C I have left for complementary drugs, that whatever new therapy keeps coming at the moment. These are SGLT2 inhibitors. Can you name any? So dapagliflozin and 10 milligram, empagliflozin at 10 milligrams. So if you follow the ABCD pattern, you know that all 4 drugs, what we talk about 4 pillars, just write down ABCD on the treatment chart and just make sure it's filled up. If it's not filled up, then you should write down not given beta blocker because of this, not given ACE inhibitor because of this. The reason is that we know that at some point we would want to start that or something similar. That is marked out that this is missing. So these are the 4 drugs you would go. Now general measures. Patient has spent 1 week in the ward, you're gradually building up on the beta blockers and everything. What general measures, what advice will you give the patient? Dietary modification. We'll come into that in more detail. Diet, what else? Exercise. So, what else? Lifestyle changes. So, if the patient is a heavy smoker, heavy drinker, ask him, stop. There's nothing about moderation, just stop. What else? Vaccination. This was covered in the morning class. So, simple thing is influenza vaccine is at least basic mandatory. Give the patient an influenza vaccine. Ideally, influenza and pneumococcal vaccine both should be given, but at least give an influenza vaccine. If money is an issue, then influenza vaccine is relatively cheaper, just costs 1,000 rupees, and patient will be able to get an influenza vaccine. Then last thing, patient is ready for discharge, is going to be discharged today. What's the most important thing in it? So emphasize the patient that you have to take all the medicines. Teach the patient about the medicine, that this drug is to be taken when, and make it simple. Take medicines in the morning or in the evening, and don't have patients taking medicine every 1 hour gap. It should be only twice or thrice a day. Otherwise patient say, मैं सुबह भी दवाई ली, उसके 1 घंटे बाद भी ली, उसके 1 घंटे बाद भी ली, दोपहर को भी ली, शाम को भी ली, रात को भी ली. ऐसे नहीं. Keep it very simple so that they know, get up in the morning, take these medicines, get up, go in the night and take up these medicines. Don't make it very complicated for the patient. And finally, discharge appointment. That means if the patient was sick, patient should have an appointment for the next visit within a week. If the patient is very sick, appointment should be within 3 days. Because you know that most of the decompensation will occur within the first week, first month and first 3 months. So those are critical periods when you don't want to have the patient searching, when should I show, kab dikhana, kisko dikhana. They should know very clearly where they have to come. So with that, let's go on to the slides. Slides on kar dijiye.
Also, how many of you know resuscitation, cardiac resuscitation? You have done it? And if a sick patient, what do you see in the monitor? And what are the immediate or prompt medicine you can give when you see something on the monitor? So what are the rhythm disturbances which can make patient sick and sometimes respond well to immediate treatment? So you know how to give DC shock, synchronized or synchronized medicine, what medicine you give for and there they go majority things.
Good.
Sometimes to answer is difficult, but sometimes some people act swiftly.
Good. So as I said, keep things simple. The heart failure occurs when the heart muscle can't pump blood. That is heart failure with reduced ejection fraction, or even if it does pump blood, it's very stiff, so at a higher filling pressure. Blood backs up, causes fluid congestion in the lungs and in the legs. Types of heart failure you were told was heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. In between there are 2 other categories. Heart failure with mildly reduced ejection fraction, which in a way behaves like heart failure with reduced ejection fraction. So the treatment will be similar to what is there for heart failure with reduced ejection fraction. That means all these 4 pillars of therapy will go. For heart failure preserved ejection fraction, there are limited drugs. I will not go into that. One new category has been introduced, which is heart failure with improved LV function. So this category is a new category because these patients are patients who had heart failure with reduced ejection fraction. Now the ejection fraction is improved. What is important for this is, for these patients you have to emphasize, do not stop the drugs. There is clear data now that if you stop the drugs, many of them will go back to a poorer LV function, and then not all of them will recover if you restart therapy. So these patients will be almost asymptomatic. BNP will be normal, they'll be doing everything. But you have to emphasize that do not stop the drugs, because whatever was the initial insult, you may not always know, might still be there. So if you stop the support, the heart function will go down again. Symptoms you already covered. You know the symptoms: shortness of breath, swelling of the feet, lack of energy because the output is very low. You can't sleep at night because you can't lie down. Your abdomen is swelling. Lungs are filled with fluid, so there's cough. Increased urination at night, because what happens when you lie down, the kidneys get better perfusion, so the kidneys start working at night. So you pass more urine at night. You're confused again because of a low cardiac output. So all these symptoms occur. See, evaluation nowadays is not as simple as it used to be initially. Initially, see the patient, make a diagnosis of heart failure, and do an echo. There is much more to evaluation. The first thing is always listening to the patient, taking a history. Quite often, most of your diagnosis will come from that history taking. Patient says, हाँ सांस फूलता है, 5 साल पहले heart attack हुआ था. You got the answers. You don't need anything more fancy. It's when the patient gives the short history, or he doesn't know the history, or he's not carrying any paper, then you need to spend more time listening to the patient, getting a ECG. As sir said, you have to know what a normal ECG looks like. That means there is a P wave, there is a QRS wave, there is a T wave. And there is always a P wave before the QRS wave. For heart failure, I always say that learn 2 more things. If the heart rate is very fast, is the heart rate regular? If it's irregular and there are no P waves, it will atrial fibrillation. This is important because you have to give that patient anticoagulation. If the ECG complexes are very wide, what we call left bundle branch block, that patient will benefit from a special type of pacemaker, what we call a triple chamber pacemaker, that will improve the coordination of the heart. So just learn how to see what is a normal ECG, and then it's not normal. Just think that if it's not normal, you should gradually pick up skills in picking up what is abnormal. ST elevation, ST depression means coronary artery disease is present. This much of knowledge is enough, and gradually you can pick up on that knowledge. Same with the chest X-ray. A cardiologist doesn't do a chest X-ray to see the heart. We know what is in the heart because we've done an echo. Where we are worried about is that we'll miss findings in the lungs. Most of the time we're not carrying stents. That's the main reason. So you have not auscultated the patient. But a chest X-ray will show there is a pneumonic patch, there is a pneumothorax, there is pleural effusion. So all these things will be picked up on a chest X-ray, and especially in the ICU. When the patient is lying down, you anyway can't examine these patients. It's very important to do a chest X-ray again for the nurses, because when the X-ray comes, the doctor is not around. See the X-ray, see is it a normal X-ray or abnormal X-ray? Is the heart dilated? How are the lungs? Are they black? Or is there something wrong? If there's something wrong, alert the doctor, call the doctor that look, the chest X-ray looks abnormal. You will gradually pick up these skills. Blood tests should be sent properly. Besides the normal hemogram routine chemistry, you need to know the thyroid function, you need to know the iron status, and if available, you want to look at the BNP. If you're suspecting a myocardial infarction or something, look for markers of cardiac injury, so troponin, CPK, LDH. Troponin is quite often more easily available nowadays, so just get a troponin level done. So these are the basic investigations you do. You have to have an echo. Again, as I said, you don't have to learn how to do echo, but there is no harm in picking up at least the skill of picking up a probe, seeing where the heart is, and seeing this is normal contraction, this is not normal contraction. At least start with that, then you can learn how to see the IVC. If the IVC is dilated, you know if there's excess fluid. Just these 2 things, LV contraction and the IVC. Learn how to do that. Besides that, then most of these patients will need some kind of investigation to find the cause of heart failure. So coronary angiogram, MRI in very unusual cases, a nuclear imaging with a stress thallium or something like that to look for ischemia. If the patient has what looks like myocarditis, we will do endomyocardial biopsy. And if there's a family history, multiple members in the family who have this, then someone has to sit down and draw a family tree. If it's occurring in every generation, is it skipping a generation, it's occurring only in males, only in females. Based on that pattern, you can often come to a diagnosis. Treatment has also evolved. Initially, there was no treatment. So if you look at the older pictures, the doctors of that time saw the patient was swollen. They said there is what they used to call bad humor. So they said, let's take it out. They would make punctures, bleed the patient, or put blood sucking leeches on the patient. Obviously, none of these patients survive. But they understood that there is something filling up the body. Now, of course, the treatment has advanced much more. It's relatively much more complicated. The initial treatment was again simple bed rest. The first two drugs that came in was digoxin or digitalis and diuretics. Diuretics initially were very toxic, very old diuretics. Now they are much better and safer to use. Then came more drugs. You understood the concept of vasodilation. That means you give drugs like ACE inhibitors, and if the patient is sick, you can give IV inotropes. Later on was the era of devices. So you understood that if the heart is not, instead of this, it's contracting like this. That means there's dyssynchrony between the septum and the lateral wall. ECG shows the left fundal branch. So putting a triple chamber pacemaker improves this coordination to this. So that's a CRT device. If the patient has had recurrent VT or LV function was very down, you could implant a defibrillator. And finally, South Africa, Christian Barnard did the first heart transplant. And with that, the era of heart transplant and surgical aspects came. Along with that came the LV assist devices also. That means you could actually implant a pump with a power supply outside. So these eras changed. In the next era, we try to do some kind of regeneration with cell therapy, stem cell therapy, gene therapy. But that came and went. And now, when we thought everything had finished, no more drugs to come, suddenly newer and newer drugs are coming. So ARNI, which is basically a combination of two drugs. There's a vasodilator and there are diuretic. Drugs like ivabradine, which just reduces the heart rate. So if you can't give beta blockers in a patient with chronic bronchitis, you can give a drug like ivabradine. Then drugs like dapagliflozin, SGLT2, and now newer drugs are coming in like vericiguat, finrenone. I'll not go into these details in too much. And then some of these patients had valve leaks. So, and the surgeons would say, obviously, this is too sick a patient, I will not tackle this patient. Percutaneous methods of actually tackling this. So, mitra clips, aortic valve replacement, percutaneous, all these procedures have now come in, so that at this point you can say that every patient of heart failure can get treatment. It is not the end of the line. It is the beginning of trying to do something and making the patient better. So now, where does the heart failure nurse comes in? See, as has been said repeatedly since morning, the doctor's time with the patient is only 5 minutes, but you are always there. You're there in the wards. When we have heart failure clinics, I insist, I will not see the patient till the nurse has seen the patient, because I know I will miss things. I'm in a hurry, I have to see 50 patients. The nurse, there'll be more nurses, there'll be research for all seeing the same patients. They are fully trained to look for signs. So all that is necessary to improve medication adherence. To counsel the patient that, look, you can live your normal life, you can do everything you want to do. You have to counsel about lifestyle, and you have to counsel them how they can go for a follow-up. Patient has to be taught about the medications. They should know you are on these 5 drugs. This is the drug which causes your diuresis. So supposing you're feeling short of breath, you don't know what to do, just take an extra tab, take an extra water pill. That should be circled. Suppose the patient says, I'm feeling giddy, my blood pressure has fallen down. You should know that the vasodilator and a beta blocker can cause a fall in the blood pressure. So these 2 drugs can be withheld by the patient himself till he can get to a doctor or nurse that, look, this happened, so I stopped this, and now I will follow whatever you say. So you have to understand which drug causes what and teach the patient that this is what is necessary. The patient has to also learn to monitor some of his symptoms. As was said in the morning, that patient should get up in the morning, go to the washroom, and then just note the weight. Simple thing, just check the weight. Once a week, they can go to a local doctor, get their blood pressure noted down, and communicate all this to the monitoring nurse or the treating doctor. And supposing suddenly the weight is going up, then you know that patient is collecting fluid, and he should be taught. If this is happening, just start taking an extra water pill, keep an eye on the fluid intake, reduce the fluid intake, and if that doesn't work, then again contact the doctor. So patient has to be empowered to treat himself, because what happens is, repeatedly we find is, suppose the patient has been treated in UN Mehta. Patient lives far away, 100 kilometers again, Rajkot. So there the Rajkot doctor will look at the prescription, he'll say 6 drugs, ejection fraction 20%, he'll say, go back to UN Mehta and go to your doctor, I will not touch you. He's worried that something happens, patient will sue him. So patient should know how to tackle mild forms of congestion, mild forms of cough and expectoration. So that training has to be given by the nurses to the patient. And simplify the medication. Just teach them, okay, these are morning pills, these are evening pills. Don't take diuretics in the evening. Diuretics is the only thing you'll take in the morning, if necessary, in the afternoon. So that night is comfortable, you're not passing urine at night. You can use various things. You can teach them how to use pill organizers, calendars. Encourage the family to be involved. The family should know what medications are, and this should be reinforced on every visit. When the patient comes, don't just copy his prescription. Ask, what are you taking? Quite often you'll find that he'll say, हाँ मैं सब कुछ ले रहा हूँ. But when you start going into the detail, you'll find you prescribe a drug twice a day, he's taking once a day. At some point, because of some hurry or something, you prescribed a Ramipril, below Ramipril is written Azmarda. That means you've given two drugs from the same group, definite interaction, people would have fallen. So these mistakes you can pick up because you know the medication now. These mistakes occur. These mistakes occur everywhere because you added a new drug. You said verbally, वो दवाई नहीं लेना, ये ले लेना. But you have not written, stop that. So patient, in all innocence, is continuing the previous medication, he has the new medication. So these mistakes occur. These have to be sorted out. As I said, then you have to explain each medicine, highlight the common side effects, teach the patient how to monitor the blood pressure and the weight, and also not to overreact to a low blood pressure. Most of these patients, properly medicated, will have a slow heart rate and a relatively low blood pressure. So they should not panic that my blood pressure was 90/100. If they have no symptoms, they should not worry about that. So they should keep a symptom diary, weight daily, same time, same machine, and any sudden change they should report to the nearest doctor. Then, as we said, general advice, pharmacological therapy, whether the patient qualifies for any device, and finally the transplant. Diet, let's go into the details. So patient should cut down on the water intake and the fluid intake, cut the salt intake, take lots of fresh fruits and vegetables, because by the time you finish counseling, you would have said namak bhi kam, khana bhi kam, tel bhi kam, everything goes down. He's wondering what I'm going to take. So you encourage them to take lots of fruits and vegetables. They will not cause any harm. They should avoid processed foods. All processed foods which come from a can have lots of salt, lots of sugar to preserve them. They can use spices as much as they want. There is no limit on the spices. That will bring in the taste. You need to add some potassium, magnesium sources. I'll show what. Because they are losing minerals from their diuresis. So water restriction is very important. We tell the patients take about 1 to 1.5 liters of liquid, and liquid means it's all forms of liquid. The water, the milk, the soup, the tea, everything comes into that limit, and it's flexible, about 1.5 to 2 liters. If it's summer, you need a bit more of fluids. In winter, you need a bit less of fluids. Then weight monitoring is there. We have what we call the Hriday card in our clinic, which basically is a small cardboard booklet kind of a thing in which there are inserts in which you can do weight monitoring. Or just note down the weight. We have realized the patients will not measure their weight every day, even though we teach it, we prescribe it. But we tell them, okay, if you can't take it every day, at least take it weekly and keep writing it down. So that when you come, and they should know what their dry weight is. That means when they were the best situation, when they were just discharged, supposing their weight is 70 kg, then if they gain anything above that, they are gaining fluid. How do you avoid thirst? They can take cold water. If you have tried it yourself, if you're thirsty, you take a glass of normal tap water, you'll take more and more. You take very cold water from the fridge, you will not be able to drink 1 or 2 glasses of water, but your thirst will go away within 2-3 sips. Then you can suck on chewing gum or mint or anything, because that brings up saliva. Your thirst will go away because you can't avoid the thirst. And if you fill a glass, always fill half a glass, don't fill the full glass. If you're more thirsty, you can take more water. So small things to ensure the fluid intake is reduced. Again, sodium. Tell the family that let the entire food for the entire family be made with less salt. Those who want normal salt, they can add their salt. Patient should not add extra salt to the normal food. So minimal salt. You don't have to make it salt free. It doesn't really work. Minimal salt, and anyone else who wants salt can add extra salt to it. Again, limit the fat and cholesterol. Don't take obviously high fat foods. Potassium sources, so we encourage everyone to take at least some lemons, some bananas, some coconut water. Simple things which are always available around the season, and any of the citrus fruits, oranges, mosmi, anything you want, these are very good sources of potassium. Things like almonds, okra, bhindi, spinach, watermelon seeds, flax, all these are good sources of magnesium. So you want minerals to go in. So anyway, the patient will ask you, 5 badam kha sakta hai? You can say, jitne badam khane khao. You will be giving magnesium to the patient besides the other benefits of almonds. Many of them will have various forms of nutritional deficiency, so it's useful to give them a vitamin capsule. So that's always very useful. Give them vitamins, give them calcium, give them vitamin D. So at least you don't have to worry about those deficiencies. And they can spice up the food. They can use chutneys, they can use spices. It will improve the food taste. Then comes the drugs. See, we talked about these various drugs that from the A group, you want some vasodilator because this will improve the long-term survival. If the patient can afford, Arni is at the moment the best drug because it causes the very significant improvement in the long-term survival. Arni contains two components, which one is a vasodilator, one is a diuretic. So often the patient will come and say, हाँ वो दवाई दी थी आपने मेरे को तो पेशाब बार बार जाना पड़ रहा है. So the diuretic starts working first, the vasodilator acts much later. Otherwise ACE inhibitors, ARBs like losartan, valsartan, candesartan, these are 3 available in India. If you can't give any of these, because each of these cause some problem on the kidneys. In a compromised patient, they can cause kidney dysfunction. In a patient with severe renal failure, you cannot give these. In a patient who's pregnant, you cannot give these. In that situation, you can give a combination of hydralazine nitrate, which is available by the commercial name of isolazine. This can also be given, not as good as the other vasodilator, but in the absence of those, you can give these. So one of these should definitely be on in the patient. Then your diuretics, the loop diuretics like furosemide, Lasix, torsemide are drugs you will use to remove the congestion. Potassium sparing diuretics like spironolactone, eprenone are drugs you will use for long-term benefit. They will reduce the potassium loss, but long-term benefit, this is necessary. Newer drugs which are coming are like the SGLT2 inhibitors, which also cause diuresis because they get rid of the glucose, and along with that they pull in some potassium, sodium, and they pull out the fluid also. Here what is important is you prescribe it today, patient comes back after 1 not taking. क्यों नहीं ले रहे? वो केमिस्ट ने कहा था ये तो डायबिटीज की दवाई है, आपको तो डायबिटीज ही नहीं है. Repeatedly this happens. 2 things will happen. Chemist's advice will be followed, not your advice. So you have to tell them this medicine is for the heart. You have to take it for the heart. It's not for diabetes. Second thing that will happen is your urine will start having sugar positive. So they should not get worried because the urine is being pushed out. The glucose is being pushed out because of the drug. And third thing is hygiene. The urinary tract has to be maintained in proper hygiene because there is sugar in the urine, infections can come in. So they have to be taught very well. Beta blockers, again 3 drugs are available. Again you have to start with very low doses. If you start with very high doses in a sick patient will crash and problem will come occur. So you have to start with very low doses and to gradually go up to the maximum dose recommended for each drug. That the criticality is starting with low doses. So again, do not start it in the ICU. Do not start in a patient who is in fluid overload, not someone who recently finished IV inotropes, and started very gradually. This is ivabradine, which is also used for heart rate reduction in the absence where you can't give beta blockers or beta blockers are not working and you want a slightly better heart rate control. Newer drugs are coming up. Vericiguat also improves the long-term outcomes of the sicker patients. So it's being tested only in sick patients, not in stable patients. In sick patients, it reduces the hospitalization. This is a new MRA. Again, it's been found to be useful in some subgroups of diseases, like heart failure with preserved ejection fraction. So these are newer and newer drugs coming up. Of course, you can't forget digoxin. It is the oldest drug. There are lots of patients who, if you can't stabilize, ultimately you give them a bit of digoxin, the patient stabilize. So you should not forget digoxin. It has some side effects. The commonest side effect is loss of appetite. So if a patient comes to you with loss of appetite, there can be multiple causes. Patient on digoxin, it could be a side effect. Just simple congestion, because because of liver congestion, intestinal congestion, it will also cause loss of appetite. So it can be drug related, disease related, either way. Now with that, what are the guidelines? Guidelines say that you should use these 4 drugs, what we repeatedly keep saying, the 4 pillars of therapy. So ACE or ARNI, beta blockers, MRAs, and SGLT2 inhibitors. So it's mandatory to give all these 4 because they're the drugs which have improved the mortality. Beyond that, give extra diuretics if the patient has a bundle branch block. Think of devices, and if the patient had a syncope or something and there's VT, or if the ejection fraction is very down, you can implant a defibrillator. Besides that, there are lots of other things you can do. Finally, if nothing else works, you have the option of a transplant. So drug failure. When do you realize that, okay, now drugs are not going to work? This is a simple protocol that we have made and validated. If the patient has had an episode of hospitalization, one or more, if there is persisting organ dysfunction, that means liver or renal dysfunction is persisting and not improving. If the BNP stays high, the cutoff here we using is 2000, and if there's exercise limitation, we ask a simple question: can you walk for 5 minutes on plain roads, or can you climb 1 flight of stairs? If you can't do that, we consider that as exercise limitation. We don't need a VO2 max, we don't need a treadmill, we don't need a 6-minute walk test. Just a simple thing like this simple question, you know that patient has exercise limitation. 2 or more of these parameters means in the next 6 months patient is going to be having some kind of trouble. So you have to be very intense with the therapy of these patients. If available, you have to think of a assist device or a transplant, because these patients may not respond to your therapy. And then of course the next steps is to consider a assist device and a transplant. Now if you look at all this, actually it becomes very complicated. Teaching the patient, for the doctor to manage everything, is very complicated. So that's why the doctor has to be supported by lots of heart failure nurses and a heart failure clinic, which we talked about in the morning also. So this is a glimpse of some of our heart failure nurses. There's a supervisor nurse and there are junior nurses who have been trained, and they're doing everything. They're the first levels of contact. We have a simple prepaid Airtel number which is there in my office. Each 2 of them are there. Patient can phone on that. If it's after office hours, the phone is still there, they can send a WhatsApp message. So it's a simple thing. Just a 2000 rupees investment and 1 phone. So in 3000, you don't need to ask the hospital. I didn't ask the hospital to give me a helpline. I just bought a phone, a simple smartphone, and took a prepaid number. That is your helpline. So 3000 rupees a year, your helpline is ready. And tell the patient it will work during working hours, otherwise send a WhatsApp, someone will respond the next day. With that, you can run a helpline. These nurses are fully trained to manage all heart failure patients, do an echo. They can look after the transplant patients. If a LVAD is implanted, they can program these LVADs better than me. So they are trained in everything which comes. And when there's a transplant, they spend more time with that patient, counseling the patient. If you list a patient for transplant, they go to the houses of those patients, if they're in the vicinity, to see is the house suitable to receive the patient after a transplant. So the water supply, what is around the house, what is in the kitchen, what is in the bathroom. So they are trained to pick up those things. Otherwise, just doing a transplant and sending the patient and he stays in a Juggi Jopri, or he stays in a very crowded area, multiple people in the same room, you know that the transplant will not survive. So all these things, they are trained. They can do all these things. They are also good at giving exercise counseling. Like in the bottom thing, you're seeing a yoga session going on. There's just some of the glimpses. So they are examining the patient, giving counseling, running helplines, all these things before the patient comes to me. So that way they will spend 15-20 minutes per patient. I will spend only 5 minutes per patient. With that, it becomes very easy to me. And this is the form that they fill in the OPD. So it's a very simple form. Patient's name, ID numbers, simple diagnosis. Is it hypertension, CAD, whatever is the diagnosis? And then the ABC. And can they climb 1 flight of stairs? If they can't climb a flight of stairs, then I'm worried. Is something wrong? And are they worse than before? Then again I'm worried. So these are red flags by which I see the patient a bit better. Then we fill the ABCD, whether the patient is on all the drugs, and just check the blood pressure, heart and weight. So simple checklist, doesn't take very long to fill, and this is retained by us. And in the ICU, when the patient is admitted, this is the ICU checklist. Diuretics, if you start diuretics, the dose should be at least equal or higher than the oral dose which the patient was taking. When you switch from IV to oral, again, give at least the equivalent dose. It should not happen that you're giving a very high IV dose and switch to a very low oral dose. Inotropes, give them only when the patient is symptomatic with hypertension. SGLT2 vericiguat can be started very early when the patient is stable. Iron should be given to all patients. 50% of our patients have iron deficiency, so giving iron without testing also is fairly okay. Then as the patient comes to the ward, start with one of the vasodilators like ACE. Start a very low dose and gradually build up. Beta blockers, as I said, be very careful, only initiate them in patients off IV diuretics and IV inotropes. And don't forget the other thing. If the patient has CAD, aspirin and all should be given. Diabetes, check the HbA1c, get an endo consult, get a dietary consult. The patient is fully counseled what to take, what not to take. Vaccination, health counseling, they look, okay, these are your things, these are your other options. Of financial consultation, that if you're going for more expensive options, can the patient be helped with some government funding from somewhere? And finally, a discharge appointment. Patient should know when to come, where to come. In some patients, it's very difficult to explain things, so we have a ABCD stamp. We just put a stamp and write down the drugs on that. This is a Hriday card. So it contains at the back, there's a pictogram which we use to give health education. And inside that, there are small inserts in which you write the medicines and you have a weight monitoring chart. So there's small little inserts in a pocket inside. Then Dr. Shantanu was supposed to talk about exercise. So what we tell the patient is, do not reduce the level of activity which you're doing. Always try to maintain that and try to be better. Some patients sometimes come to me in a wheelchair. So I tell them one thing, that in the heart failure clinic, there's only one rule: no wheelchairs are allowed. So that means that is a motivation for them, that I believe that they can walk unless there's an amputation. In fact, even with the amputation, I had one doctor from Jammu. I said, I don't care about your amputation, I want you to walk. He comes back after 3 months and he's walking in. He had a prosthesis put. He said, because you said I have to walk, he got a prosthesis put and walked in. So that you have to give that patient the motivation that, look, the doctor believes that you can walk. Then the patient will start walking. Otherwise, they sit on a wheelchair, they come into the clinic in a wheelchair at home, they're assisted to even go to the toilet. So it is possible. And these are the simple exercises which we try and teach them. These are all exercises in which the person is sitting on a chair so that there is no risk of falling down. So sit in a chair, lift your hands. Many of our patients, as they become elderly, they get frozen shoulders. So if you lift your hand every day, you will not get a frozen shoulder. Then lift your legs, bend your legs, lift your heels. Basically, each joint is being covered without getting up from the chair. And finally, bend down, touch your toes, and then stand up. So everything is from a chair. And if you achieve that, then you know that patient who was bedridden is now at least ready to walk. Then we tell them, walk as much as you can comfortably do for 5 minutes, 10 minutes, and rest in between. So these are the kind of exercises that we teach. So supposing you want to start a heart failure clinic, your doctor wants to start a heart failure, it is not complicated. For doing all this, you don't need any complicated system or machines or anything. You just need a room. Supposing you run a clinic every day for 5 days, one of the days, 2 hours can be defined as your heart failure clinic. And anyone can come and help you. The first few people I got to help was initially a medical rep. He said, I'll help you for 2 hours. During that time, I will not be a medical rep. I'll just help you with whatever you want. So I said, fine. Just write down the patient's name and medicines and put them on a Google sheet. So that was the first step. Then we have a college of nursing. So they said, we want to do some MSc thesis. So every 6 months, I would get one thesis student who's an MSc, so already well trained. We would give them very small projects. But in that, I got some support. Then once all this was done, then I asked for help from the institute. That look, I can't manage all this alone, the running clinics, running transplant pain. Then I asked for only one nurse. The chief said, you can't do anything with one nurse, she'll go on leave. I got 4 nurses. So you have to first prove that you can do something without resources. Then when you prove that you are good doing something, then when you ask for resources and patients are happy, then you can get in more resources. At that point, more and more nurses can be part of the program. Then we use these, what I showed you as the Hriday card for education, medication adherence and data collection, simple helpline. All these things, even in a private setup, possibly you can do such a thing, but the difference in a private setup will be if there are 5 cardiologists, each of them will feel we can manage the patient, we don't need a clinic. So the clinic has to be set up by all 5 cardiologists in unison, and it should be a clinic run by all of them. That means they send the patient there, there's a junior doctor sitting there, and there's a nurse who are trained. They will see the patient, fill in the checklist, give counseling, send the patient back to the same doctor. That way, that fear of losing a patient will not be there, which is anyway not there in a government setup, but private setup, obviously, this is a major issue. So, that is in essence what you need to do as a heart failure nurse, and how you can start and support a heart failure clinic. You can take a photo of this QR code. If you scan this and go to it on this website, quite a few of these resources will be available on that. There's a heart failure manual for nurses also on this. A copy of the Hriday card is also on this. So very simple things are there, and which you can read through. Okay, thank you very much.